This program is brought to you by Emory University.
Okay, hi, good morning. It's my pleasure to introduce one of our own, Dr. Faisal Marchant, who has come all the way from Midtown. And if you ever tried, looking on the map, Midtown is, it's not too bad, it's close. But whenever I get in the car to drive there, I'm like, oh my gosh, traffic. So Dr. Marchant went to Duke for medical school and Brigham for internal medicine and cardiology, and then did his EP training here. And he's been very interested in sudden cardiac death risk stratification and ICDs, and also atrial fibrillation. And he's going to talk to us today about whether to screen or not to screen. An important topic, and I can't wait to learn.
Absolutely true. Yep. Right next door. So morning, everybody. Thanks for the invite to be here. Obviously, I'm going to be talking about atrial fibrillation and screening for subclinical atrial fibrillation, and spend a fair bit of time talking about wearable technology and the kind of direct-to-consumer devices that we're all seeing a lot more of in our clinics, and I think we'll continue to. I titled the talk, whether we should be screening or not, and I think that there are probably certain patient populations where it might make sense to screen for subclinical atrial fibrillation, but I think the truth is the horse is already out of the barn. As patients or as individuals are able to buy these devices that are enabled, we're going to be stuck having to interpret and deal with the data whether we chose to initiate the screening or not. So we'll talk a little bit about how to interpret out of this data and how to make decisions about anticoagulation in particular. So just as an outline of the talk, we'll talk about some of the newer devices, how they screen, what the algorithms are in as much as any of that's publicly available, what kinds of populations might be ones that we would think about screening. Treatment, we'll spend a fair bit of time talking about the data on anticoagulation for subclinical atrial fibrillation, and then finish up talking about a lot of the pitfalls of screening and why I think that this is going to be a really challenging field moving forward. I do want to start out just with a sort of an operational definition. Everything that we're talking about from here on out is going to be asymptomatic subclinical atrial fibrillation. So we're not talking about people who have symptoms. I think a lot of these, as we were just talking about, wearable devices for people who have intermittent palpitations can be quite useful. You may not catch something on a 30-day monitor. If they get symptoms, a few times a year, you buy a device, you have symptoms, you can obtain a tracing, and that's useful for symptom rhythm correlation. But that's not what we're talking about here. We're talking about asymptomatic subclinical AFib, typically defined as short, and we'll talk a fair bit about duration, and then usually detected by some kind of continuous rhythm monitoring. In contrast, and it's really a very arbitrary distinction, but clinical atrial fibrillation either has symptoms, or most studies say that AFib that's documented on a 12-lead EKG counts as clinical, whereas if you pick it up on continuous rhythm monitoring, it's subclinical. And again, that's a very arbitrary definition, but that's what we'll use for this. So before we get too into the screening, I do want to mention briefly, and this will come as no surprise to anybody in this room, but why you would even think about screening people for subclinical atrial fibrillation. And the truth is that AFib is obviously common. For the kinds of patients that we see a lot in our clinics in their 60s, 70s, 80s with cardiovascular risk factors, the prevalence of AFib over the age of 65 is probably about 10% or so across the population. So there's a lot of it out there if you look. It's a major cause of ischemic strokes. About a quarter of ischemic strokes are attributed to atrial fibrillation. And strokes due to AFib are bad. If you look at these figures here on the right-hand side, the extent of neurologic disability up to a year out from a stroke attributed to atrial fibrillation and overall mortality are much higher if AFib was felt to be the cause of stroke as opposed to a non-AFib related stroke. And anticoagulation, particularly with novel anticoagulants that are a little less cumbersome than warfarin, is both very effective and quite safe. And so I think the rationale that you could identify subclinical atrial fibrillation, intervene with upstream anticoagulation, and prevent a subsequent stroke makes some sense based on this paradigm. But we'll talk about some of the areas where that might break down. I think in my kind of cynical view also, a lot of the reason that this is coming up now is just that it's feasible. There's obviously a huge market for direct-to-consumer devices, and it's actually not very hard to embed ECG electrodes in wearable devices, watches, or phones. And so there's a market for it, and that's why it exists, whether it's clinically indicated or not. A lot of the data to screen for subclinical atrial fibrillation has sort of emerged in the last several years since the publication of the ASSERT study. So I want to go through this a little bit because it really set the stage for everything that's come since then. ASSERT was published in 2012 in the New England Journal. And what the ASSERT investigators did, take a cohort of patients who were undergoing pacemaker or ICD implantation. So already that's a relatively select group because they've got a clinical indication for device implantation. All over the age of 65, so again, the background incidence of atrial fibrillation is likely to be relatively high. And they use the pacemaker or the defibrillator atrial leads to screen for atrial fibrillation. And in ASSERT, they define subclinical atrial fibrillation as anything lasting more than 6 minutes. And we're going to come back to these time thresholds. But the 6-minute number really came from ASSERT. Couple of interesting things. If you take a cohort of about 2,500 people newly implanted with pacemakers or defibrillators who have never known to have any clinical atrial fibrillation before, by 3 months, about 10% had episodes of subclinical AFib lasting at least 6 minutes. And if you follow people out for 2.5 years, about a third of individuals had subclinical AFib. We see this, you guys get messages from our arrhythmia clinics all the time about so-and-so had an episode of AFib detected on their device. So this is something we all deal with on a daily basis. The two interesting things from ASSERT were that subclinical AFib seemed to predict the development of clinical AFib. So you're about 8 times more likely to go on to develop clinical AFib, either symptomatic or presenting in some clinical way, if you had subclinical AFib. And the incidence of ischemic stroke was about 2.5-fold higher if you had subclinical AFib detected on your device. So this really set the stage for the idea that if you could screen in some fashion, you may be able to intervene upstream, i.e. anticoagulate, and prevent the subsequent risk of stroke. And since then, obviously, there's been a massive proliferation in the kinds of devices that can be used for screening. There are invasive devices, so pacemakers, defibrillators that have got atrial leads, the kind of implantable monitors that we frequently implant that can be used for detection of atrial fibrillation. The technologies that are used for screening really break down into 2 big categories. There are those that use ECG to screen, and then those that are based more on pulse or pulse waveforms. A lot of the blood pressure cuffs that people can buy that screen for atrial fibrillation obviously use pulse, and we'll talk about some of the photoplethysmography-based devices. And then screening can either be continuous, intermittent, or opportunistic. A lot of the devices, obviously a pacemaker, if you have one, is continuous screening. The atrial lead screens all the time. If you have an Apple Watch, for instance, then that would be more intermittent. The times that you're wearing the watch, it's screening, but not if you're not wearing a watch. And then opportunistic screening, the kind where you screen people when they come into primary care clinics, whether they need to have an EKG done or not. You just do one routinely and see if you happen to pick something up. But obviously, there's a lot of possible ways that you can screen people for subclinical AFib. I'm not going to get too into the details. A lot of these individual studies have been a lot of relatively small studies looking at the sensitivity and the specificity of these devices. And one of the reasons that it's hard to compare across studies is that the gold standard that was used to identify the rate of false positives and true positives varied from study to study. But across the board, if you look at a number of different either blood pressure cuffs, wearable devices, manual pulse palpation, sensitivity and specificity tends to be in the mid-90% range for diagnosis of atrial fibrillation. So if you happen to check someone's pulse with a blood pressure cuff while they're in AFib and compare that to a 12-lead EKG, most of the time the blood pressure cuff with the automated algorithm does a reasonably good job of detecting atrial fibrillation. From a screening point of view, it would seem like if you could get sensitivities and specificities in the mid-90% range, then that would make for a relatively robust screening test. The problem is that when we start trying to apply these devices in populations that have a very low background incidence of atrial fibrillation, false positives become a huge problem. We'll come back to that a little bit later. But on balance, the sensitivity and specificity for most of these devices seems relatively good. I do want to spend a few minutes talking about photoplethysmography specifically. This figure here is taken directly off the Apple website, which actually does a relatively good job of explaining the technology behind which these devices, or the technology they use to screen for atrial fibrillation. I'm going to talk a fair bit about the Apple Watch specifically and also about the Apple Heart study, since those have kind of dominated the lay press in this field for the last few years. But the same technologies are applicable to a number of devices. Fitbit, Garmin, and a lot of these manufacturers use similar sorts of technologies. But the primary way that the Apple Watch, if any of you guys have one, screens for atrial fibrillation is through photoplethysmography, which in essence is a little bit like pulse oximetry. If you flip the watch over, there's a crystal on the back, and there are LEDs embedded in the back of that crystal. If you flip over the watch, you can see them. And there are infrared LEDs and green light LEDs. And the relative absorption of green and red light on light emitted from the back of the watch varies based on the volume of blood in the microvasculature. And that volume of blood varies as a function of cardiac output or pulse. And in essence, the ratio of green to red light absorption is how the device detects a pulse waveform and tries to determine whether you're in atrial fibrillation or not. They don't really present any data, but Apple says that the algorithm that they use for red and green light photoplethysmography can detect heart rate relatively accurately, not necessarily AFib, just heart rate, over a dynamic range from about 30 beats per minute up to about 210 beats per minute. So it's relatively robust in that regard. And they don't really talk about their specific algorithm, but in essence, the way the PPG works is you can imagine that using the absorption of red and green light, you can get something that looks like a pulse oximetry tracing. And you can use both the amplitude and the irregularity of the pulse interval in order to develop an algorithm to try to detect atrial fibrillation. Here in sinus rhythm, you can see a nice regular PPG waveform. If you've got a very high fidelity tracing, sometimes you can even see a dichrotic notch. But the amplitude and the pulse interval is quite regular. If you're in atrial fibrillation here, which you can see on the EKG, not only obviously is the pulse interval very irregular, but the amplitude varies significantly as a function of the preceding diastolic interval and the subsequent pulse pressure. Now you can imagine right off the bat that there's going to be a lot of potential for false positives if the way that you're determining AFib is not necessarily through an ECG, but using what amounts to a pulse oximetry waveform. PACs, PVCs, just noise from the watch not being very well in apposition to your wrist may lead to false positives. So how well does this work? There's not actually that much data available, and Apple hasn't put out a whole lot of their data. We'll talk a little bit about the Apple Heart study, but this was another study that of about 600 patients in the hospital for other reasons. And they had patients do a 1-minute recording with both the AliveCor band here, which you see a lot of people, which gives you a single lead EKG, and then a different, non-Apple, but a different PPG-enabled watch. And if you took 1-minute recordings, one of the things that I want to highlight is using the PPG, about 22% of the recordings were deemed insufficient quality in order to make a decision about the rhythm. And so non-diagnostic data is going to be a big problem. You get either messages saying the rhythm's inconclusive, you can't make a determination. So there is a high rate of non-diagnostic data, but if you exclude the non-diagnostic data segments and compare the PPG to the ECG, again, the PPG gives you sensitivities and specificities in the mid 90% range. So if you can get reasonably high quality data on people sitting in a hospital, not moving up and around at the grocery store, wearing their watch or out exercising or that kind of thing, but relatively high quality data, you can get decent sensitivity and specificity. Now, in my mind, this is probably about as good as you're going to get with the data. In ambulatory folks, young, healthy individuals, these numbers are likely to go down. But under optimal circumstances, PPG seems to work relatively well for identifying atrial fibrillation. Now, PPG was the primary mechanism by which Apple incorporated AFib screening into their first 3 generations of the Apple Watch. So the Apple Watch generations 1, 2, and 3 all use PPG. A couple of years ago, when there was a lot of fanfare when Apple released the Apple Watch 4 and they did this sort of big joint press conference with the AHA, that was the Apple Watch 4 and now subsequently 5. What the last 2 generations of Apple Watches have done is incorporated the ability to obtain a single lead ECG. The way the single lead ECG works is if you can imagine wearing a watch on your left wrist and you embed an ECG electrode on the back of the watch, right where those LED sensors are, and then you take the finger on the right hand and touch that to the crown of the watch, and you embed another ECG electrode on the crown. Now, in essence, what you've got is a right arm, left arm ECG, and you get something that looks very much like ECG lead 1. And most of the devices that incorporate this kind of ECG screening use a right arm, left arm electrode of some variety and get something that looks like ECG lead 1. So the big fanfare was that Apple had incorporated a way to generate a single lead ECG from the watch. Now, it's important to remember that the watch doesn't continuously record an EKG. The ECG is not the primary mode of screening. Even Apple Watches Series 4 and 5 still use PPG. So every couple of hours that an individual wears the watch, the device in the background takes a PPG tracing. If it looks regular, doesn't detect an irregularity, it checks again in a couple of hours. If it detects an irregularity, it increases the frequency of PPG screening to about every 10 or 15 minutes or so. And if over the course of several recordings in a shorter time window, it continues to detect an irregularity, it prompts the individual wearing the watch to say, an irregularity has been detected, you may want to consider obtaining an EKG, and then the person can obtain a 30-second EKG, and that's how it correlates ECG with the PPG screening. But the background operation is still PPG based. The other thing that I thought was interesting that I didn't realize until I started looking into this is that just based on the way that Apple set up their algorithm, a regular PPG waveform with a heart rate of between 50 and 100, it defines as sinus. An irregular PPG waveform between 50 and 120, it says possible irregularity, maybe atrial fibrillation. But the algorithm that they use actually gives you an inconclusive, even if it's irregular, if the heart rate is less than 50 or over 120. So if an individual goes into AFib with RVR, which a lot of people, when they go into AFib and they're not on nodal agents, tend to be relatively fast, the device won't actually document that there's possible atrial fibrillation. It'll just say inconclusive because the heart rate's too high. So Apple's algorithm for detecting atrial fibrillation using PPG is only optimized between about 50 and 120 beats per minute or so. And outside of that window, it's inconclusive. But that's basically the way the watch works. There are obviously a number of other manufacturers, Fitbit, Garmin, who make similar sorts of devices. The other big one that I think we see in clinic a lot, I see a lot of folks with these devices, Dr. Clements just showed me his, is the AliveCor Kardia band. And this is obviously not watch-enabled, but it's this little strip that you can buy and attach on the back of the phone. The original generation of the Kardia Mobile over there on the left side of the screen worked in exactly the same way. It's got basically, you put the thumb or a finger of the right hand and the left hand on that little strip, and it uses it to generate a single lead, roughly ECG lead 1, right arm, left arm electrode that then is displayed on the phone. You can save it as a PDF, send it to your care provider. What Kardia has recently released is the Mobile 6L. You see a lot of ads in medical journals for the 6-lead EKG. But the way that they have obtained the 6 leads is to put another electrode on the back of this strip. So you still hold the top of the strip with the right arm and the left arm, but then you touch the back of the strip to either your left ankle or the left knee if you're wearing shorts or something like that. And in essence, then you've got right arm, and left leg, and you can generate all of the precordial leads that way. So you get a 6-lead EKG that looks very much like our limb leads would. Sorry, you get the limb leads, you don't get the precordial leads. But you can get 6 leads that look very much like the limb leads on an EKG. And so that's the way that the 6L works. So obviously we see lots of people anecdotally who are wearing these devices, but I feel like every biotech Silicon Valley pitch probably starts with a slide that looks like this, but they're expected to be about 1 billion connected wearable ECG-enabled devices by 2021. And the annual market for these in 2018 was $50 billion and is only expected to grow. I mean, I think most devices that we see moving forward will be biosensor enabled in some way. I mean, obviously there's a lot of interest in screening blood pressure, screening for blood glucose. ECG is already out there, so I think we'll continue to see a lot of this. We had a lot of this in clinic. I'm sure many of you do also. And so I want to transition a little bit now specifically to talking about the kinds of patients who you might consider using this technology in, and then what to do with the information. I think there's probably 3 big groups of individuals where you could talk about the potential for screening for subclinical AFib. The one that makes the most sense in my mind are those who have had already an embolic stroke of undetermined source, or what used to be called cryptogenic stroke. In them, obviously, there may be some rationale for screening for subclinical atrial fibrillation. We'll talk about crystal AF. You could consider screening people who are at high risk for AFib but don't actually have clinical AFib. And then you can talk about screening everybody else, so just young, healthy, asymptomatic people. And those are the kinds of people who ended up in the Apple heart study, which we'll talk a little bit about. At least in terms of the post-cryptogenic stroke or the post-embolic stroke of undetermined source, Crystal AF was the big study that looked at this. A few others have done similar sorts of things. But Crystal AF took a group of patients who had already had a stroke that looked like it was of embolic origin, and whatever workup, carotids, echo, bubble study, non-invasive event monitor, Holter, whatever other workup needed to be done was done, and still no clear source was identified, and embedded them all with these implantable loop monitors or implantable rhythm monitoring devices, and looked to see what the incidence of subclinical AFib was in the months and years after you already had presented with a stroke. Now, Crystal AF defines subclinical AFib as anything lasting more than 30 seconds, and we'll come back to these time cut points in a little bit. But if you screen people for 3 years after they've already had a cryptogenic stroke, the incidence of subclinical AFib using this definition was about 35% or so. So about a third of these individuals had subclinical AFib detected after they'd already had their stroke. Now, in these individuals, I think there probably is some rationale to screening and anticoagulating. Again, how much subclinical AFib is enough to justify anticoagulation is very unclear, but at least in some ways, if we believe that AFib may have contributed to the initial stroke, then from a secondary prevention point of view, I think anticoagulation, if you identify subclinical AFib, makes sense. Now, you could reasonably argue that if that curve were to continue to trend up over the next several years or so, that if you screened enough people with cryptogenic stroke for long enough, eventually you'd find subclinical AFib in the vast majority. So maybe we shouldn't even screen. Maybe we should just empirically anticoagulate everybody after they've had a stroke of unknown origin, particularly if it looks embolic. That's exactly what Navigate ESUS and Respect ESUS tried to do. These were just both published in the last year or so. Navigate used rivaroxaban, Respect used dabigatran. Post-embolic stroke of undetermined source, didn't stratify them for subclinical AFib in any additional way, randomized to anticoagulation or usual care, which is usually aspirin. And interestingly, both studies showed no significant benefit to empiric anticoagulation after a cryptogenic stroke. And not surprisingly, bleeding rates were higher in those who were anticoagulated. So I don't think this is going to be as straightforward as saying we ought to just anticoagulate everybody. I think we're going to need some way to enrich for those who are most likely to have AFib as a cause of their stroke. And what kind of screening that entails, I think remains unclear, but I think we'll need something, or something makes sense. So those are people who have already had a stroke of undetermined source. You could also consider screening just sort of the average patients that we see in our clinics, those who are a little bit older, in their 60s and 70s, who have other cardiovascular risk factors, because we know that the background incidence of atrial fibrillation is relatively high. That's what the REVEAL AF study did. Took 385 patients. All of them wore non-invasive monitors beforehand and did not have any AFib identified on the non-invasive monitor and did not have any known clinical history of AFib. All of these individuals also had to be higher risk for AFib, meaning a CHADS-2 score of at least 3 or a CHADS-2 score of 2 with an additional risk factor. And the mean age was in their 72. REVEAL AF used the same 6-minute definition that ASSERT did for subclinical AFib. And if you take a bunch of individuals who roughly meet that profile and screen them using implantable monitors, out to about 30 months or so, the incidence of subclinical AFib lasting at least 6 minutes was 40%. So very similar to that ASSERT sort of number in the 30-40% range. So if we take a lot of the folks in our clinic in their 50s, 60s, 70s who have cardiovascular risk factors and start screening them, probably about 30 or 40% of them will have subclinical AFib for at least 6 minutes if we look long enough. Now again, what to do with this information remains very unclear, but there is a lot of it out there. I think the much more vexing problem in the much larger number of potential patients are screening people who are asymptomatic and not at particularly high risk of atrial fibrillation, sort of young, healthy, walkie-talkie people. And that was in essence what the Apple Heart study tried to do. And I want to spend a few slides going through the Apple Heart study. It hasn't been published yet, and so everything I'm going to present is based on the slides that were presented at ACC earlier this year. But what Apple Heart did was anybody who had an iPhone 5S or subsequent and Apple Watch generations 1, 2, or 3. So these were only the PPG-enabled Apple Watches, not the subsequent generations 4 and 5 that can do the single lead ECG, but only PPG-based screening. Anybody who had an enabled device could go online, sign up to be a part of the study. And in essence, the way the study worked is anybody who had known AFib was excluded, in theory. once you had your watch and the phone, you're out and about in the world doing what you do. If the device detects any irregularity concerning for AFib, you got an alert and were connected over the phone to a telehealth doctor. And subsequently, a 14-day ECG patch, like one of those Zio patches, was mailed out. You wore the patch for 14 days, and at the end of 90 days, completed the study protocol. Now, one of the things that's impressive is that in about 7 or 8 months worth of enrollment, 420,000 individuals signed up to be a part of this study. So you can get a lot of people in a very short amount of time. Whether that's a good thing or not, I think is unclear. But a lot of people signed up. Only about 2,000, so the incidence of irregular pulse notifications concerning for AFib was only about 0.5%. And of that 0.5%, only about 1,000 decided to go through with that telehealth visit, of whom 658 agreed to have the patch shipped out to them, and only 450 returned the patch. So the number of people who underwent confirmatory ECG patch testing out of 420,000 enrollees was 450. And these are the folks, I think, that really have the usable data, because it allows you to compare the watch to something. So the amount of unusable data is actually fairly substantial. But suffice it to say that they were able to at least enroll a large number of people in a short amount of time. If you look at the kinds of people who enrolled in the study, not surprisingly, the overall study cohort, 420,000 or so, tended to be relatively young. Mean age was 41. So these are young, healthy, tech-savvy, Apple Watch, iPhone, want to sign up online for a study kinds of individuals, relatively healthy. The folks who got about the 0.5% that got the notification were significantly older, much more likely to be in their 50s and 60s, and had a higher CHD-VASc score. So it does seem like the people who are getting the irregular pulse notifications are the kinds of people you might expect to have subclinical AFib. The incidence of irregular pulse notifications in people over the age of 65 was about 3%. Between 55 and 64, about 1.3, 1.4%, and then much, much lower in the 0.2, 0.3, 0.4% for the younger individuals. Now, if you wear a watch and it alerts you that you might have AFib, by virtue of the paroxysmal nature of the disease, if somebody mails me a patch 2 weeks later and I wear the patch and I don't happen to have any AFib while I'm wearing the patch, that doesn't necessarily mean the watch alert was a false positive. It just means I may not have had any AFib in the 14 days that I wore the patch. So for the folks who had alerts but then did not have any AFib while they were wearing the patch, it's very hard to know what to do with any of that information. I think the most useful group, like I said, is that smaller number, about 450 or so, who got mailed the patch and happened to have AFib on the patch while they were still wearing the watch, because there for that 2 weeks, you could do a direct comparison of the sensitivity and specificity of the watch using the patch as the gold standard. And there, if you look at the people who got notifications while they were wearing the patch, 86 notifications, of whom 72 had confirmed AFib on the patch, which gives you a positive predictive value for the watch of 0.84. So good, certainly not great. These are some numbers that were provided by Venk Murthy at the University of Michigan, who's written a lot about this. But if you look at that group of 450 that had AFib while they were wearing the patch, there were 72 true positives, which we talked about, 14 false positives, meaning the watch detected what it thought was AFib, but the patch showed sinus rhythm or noise or some other cause of false positives. Interestingly, there were 81 false negatives, meaning the patch detected atrial fibrillation, but the watch did not detect any irregularity, or it was an inconclusive tracing. So it's a relatively high number of false negatives for a small denominator of 450. And if you calculate it, then you get a sensitivity of only 47% and a specificity of 95%. So if you see AFib, or the watch alerts you to AFib, there's a reasonable chance that it's there, but it's not very sensitive. There's a lot of false negatives. So for a screening study, obviously that's concerning because false negatives are a problem. What to do with this data moving forward, I think, remains very unclear, but this is what's been published so far from the Apple Heart study. There's one other study that's looked specifically at the sensitivity of the Apple algorithm. This was using the Apple Watch 4 and 5, which was ECG enabled, and implanted only 24 patients with implantable loop monitors, and the implantable loop monitor then served as the gold standard to compare to the watch. This is an older group of people in their 70s, higher prevalence of cardiovascular risk factors. In this cohort, where the background prevalence of AFib is likely to be much higher, sensitivity, not surprisingly, looked better, but the positive predictive value wasn't very good. There were a lot of false positives. So again, I think false positives and false negatives are going to continue to be a big issue in this field. One other study that I wanted to highlight was just published in JACC this year, the HUAWEI heart study, very similar to the Apple study, but this was obviously from China with PPG-enabled HUAWEI watches. PPG-enabled HUAWEI phones. Enrolled just under 200,000 patients, again, in a very short amount of time. Same kind of thing. If the phone detected an irregularity, you got mailed a patch as a confirmatory measure, and they reported a positive predictive value of about 92%. But again, none of these people we don't know what happened to them in terms of anticoagulation. We don't know what the background incidence of thromboembolic events was or any of that kind of stuff. These are just big, large screening studies. So the question is, if there's a lot of people walking around with these devices, and we're going to end up detecting a fair amount of what we think may be AFib, what do we do with that information? And I think we're already starting to see a lot of people coming into our offices saying, I bought this 6 months ago, I got an alert saying I had an irregular pulse, what do we do now? And I think you can break down the what do we do now into two things. Risk factor modification, I think, is an obvious low-hanging fruit, right? If people have risk factors for AFib and you're detecting subclinical atrial fibrillation, obesity, moderating alcohol consumption, managing cardiovascular risk factors, screening for sleep apnea if it looks like it might be present, that all makes a lot of sense. Because doing those things may slow down the progression to clinical AFib. May, I say that. We don't necessarily know if that's true, but it makes intuitive sense. Whether it makes sense to screen a lot of people and run the risk of a lot of false positives and false negatives simply to motivate risk factor modification, I think is very unclear. I think if risk factors are present, it probably makes sense to treat them and not go through the whole exercise of screening for subclinical AFib. The more vexing question then becomes anticoagulation. When do you make a decision to anticoagulate people, and how do you make that determination? As we said already, ASSERT was the big study that sort of initiated this field, and ASSERT in the original paper used a 6-minute cut point and reported an increased risk of ischemic stroke in those who had subclinical AFib lasting more than 6 minutes or so. And so for a long time in the literature, and people even clinically, myself included, if we saw people with pacemakers and defibrillators that were having subclinical episodes of more than 6 minutes, I think Mike's probably doing this also, if their CHADS2 VASC was sufficiently high, we would initiate anticoagulation. The investigators from ASSERT went back and published a paper in the European Heart Journal a couple of years ago where they subclassified those episodes of subclinical atrial fibrillation into more granular time periods. They categorized episodes that were more than 6 minutes but less than 6 hours, between 6 hours and 24 hours, and those who had subclinical episodes lasting more than 24 hours. And interestingly, the bulk of the increase in ischemic stroke risk seemed to be in those who had subclinical episodes lasting more than 24 hours or so. Shorter episodes did not seem to predict an increased risk of stroke. So the duration of the episodes seems to be important, and the very short episodes may not portend as much risk. I put this slide together to summarize some of the data in the field. It's a busy slide, but a number of studies have looked at how long these episodes are and looked to see whether the duration of the episodes predicts subsequent stroke risk. And if you kind of think about it along an axis from those who have no subclinical AFib and their background rate of stroke is whatever it is in the population that doesn't have AFib, and then kind of think about it as a continuum from episodes that last just a few minutes to episodes that last several hours, and then episodes that last more than 24 hours or so. At the very short end of the spectrum, the rate registry was a registry of a couple thousand individuals who had pacemakers or defibrillators, and they looked at atrial high rate episodes on the devices, which are very short episodes, usually on the order of 30, 40, 50 seconds, a minute or two, that we detect when interrogating pacemakers and defibrillators. And at least from patients implanted with the devices, those very short atrial high rate episodes did not predict any increased risk of stroke, which is sort of consistent with the 6-minute data from ASSERT. So at least the current thinking seems to be that very short episodes lasting just a few minutes don't sufficiently increase the risk of stroke to justify anticoagulation. As you start to get into episodes that last more than an hour or a few hours. TRENDS was another study that looked at a 5.5 hour cut point. The risk seems to increase along some kind of gradient to where you get episodes more than 24 hours or so in both the ASSERT sub-study, and there was a large study from the VA looking at the benefit to anticoagulation in subclinical AFib that suggested that the greatest benefit was in those that had episodes of more than 24 hours or so. So I think risk clearly goes up if you have episodes more than 24 hours. If you have episodes of lasting just a few minutes, risk is probably relatively low, and then there's some gradient of risk in between. But where the cut point lies and whether there's a clear inflection point in risk based on duration, we don't really know. To throw another wrench into the works in terms of how to deal with this data, the KP heart study was presented, or KP rhythm study last year. This was a large Kaiser Permanente cohort from California of individuals who had paroxysmal AFib detected while they were wearing a 14-day Zio patch that was ordered for clinical reasons. And the investigators went back and looked at the burden of atrial fibrillation detected during that 14 days and divided the burden into tertiles, with tertile 1 being less than 2% and tertile 3 being a burden of more than 11%. And interestingly enough, and maybe not surprisingly, the burden of atrial fibrillation was a much stronger predictor of subsequent stroke than the single longest episode. The single longest episode was not nearly as strongly correlated with the subsequent risk of stroke as the overall burden. So it may be that a lot of this effort that's been put into defining the single longest episode cut points over recent years may be barking up the wrong tree, and what we really should be looking at is the overall burden of atrial fibrillation on whatever the rhythm monitoring device is as a predictor of subsequent stroke. It does make sense that burden may be what matters. I mean, for many years now, it's been observed going back through clinical trials of anticoagulation that the risk of stroke is higher in those who have persistent AFib, i.e. a higher burden, compared to those who have paroxysmal AFib. And the same may be true for the kind of subclinical AFib that's detected from devices. But again, we don't really know what the relationship is between burden and stroke risk. Is it a linear or kind of monotonically increasing relationship? Is there some sort of threshold of burden? And how is that threshold impacted by the baseline stroke risk? And how to characterize exposure, whether we should be looking at single longest episode, whether we should be looking at burden, remains very unclear. But I think the field relatively quickly is going to have to figure some of this out with this deluge of data that's coming through our clinics as people have these devices. I put this slide in here because I think it roughly summarizes the way that I and most people are starting to think about this. But I think the decision to anticoagulate really has to be looked along two axes. There's the background stroke risk, right? For people who are very low risk, CHADS2 VASCs of 0 or 1, or maybe a CHADS2 VASC of 2 in a woman, as the burden gets higher, it's not clear that anticoagulation would necessarily be beneficial regardless of what the burden of subclinical AFib is if the background stroke risk is very, very low. So for people who are at low stroke risk, I don't think anticoagulation is necessarily relevant. Again, we don't have good data, but other than risk factor modification, I'm not sure there's a lot to do with this data in people who are already at very low background stroke risk. And so if you're not going to anticoagulate them, whether it makes sense to screen in this population, I think is very unclear. My bias would probably be not. For people who are at higher stroke risk where you would consider anticoagulation, CHADS2 VASCs of 2 or above, as the episodes of subclinical AFib increase either in duration or in burden, generally I now start to anticoagulate people when their episodes get into the 10, 12, 15, 20 hour range. But I know that all of us use different cut points. I'm sure all of you have to deal with this also. But that's where I think anticoagulation becomes the most relevant. For all these other lower risk individuals, I'm not sure that the background burden at this point matters if it's all still subclinical device detected atrial fibrillation. Now this is hard obviously because we work much better if we just have a clear cut point. If burden X, anticoagulate. If burden less than that, don't. But unfortunately, absent better data, we don't really have that to guide management at this point. I want to spend the last few minutes here talking about some of the pitfalls of screening, of which we've alluded to many of them already. I put this slide in here just for the sake of completeness, but there's really no data to suggest that anticoagulation for only device-detected subclinical atrial fibrillation is beneficial. The U.S. Preventative Services Task Force put out this document. It's a systematic review published in JAMA last year, where they looked at a number of screening studies. And not surprisingly, if you screen people, whether you use ECG-based screening or pulse-based screening, you detect more atrial fibrillation. But again, there's absolutely no data to tell us whether anticoagulation is beneficial or not. I think the biggest challenges to using this data are the high rates of non-diagnostic data. I do want to talk for a couple seconds about the temporal association between subclinical AFib and stroke and why that really confounds the issue also. We'll talk a little bit about the false positive problem and then net clinical benefit, particularly when it comes to anticoagulation. We've alluded to this already, but there are a lot of high rates of non-diagnostic data when people are wearing these devices. Obviously, how clean the data is if you're out and about ambulatory, doing things, moving your wrist, if the device is trying to sense pulse waveforms from the back of your wrist, is a real challenge. In that initial study that we looked at of the 600 or so hospitalized patients, there was a rate of non-diagnostic data of about 20%. This was a study just published in JACC last year. It's only 100 patients undergoing elective cardioversion in the hospital, and they screened them using the ECG-enabled watch before cardioversion and after, and compared what the device detected to a gold standard of 12-lead EKG. And only 2/3 of people had interpretable data from the watch. And this is really a best case scenario, sitting in the hospital, waiting for your cardioversion, not moving around as part of a clinical study. I think the level of diagnostic data is only likely to go down in ambulatory individuals. And so if people get inconclusive or non-diagnostic recordings from their devices, what to do, how much subsequent testing to do, if any, is a real problem. Another big problem with this field in general is that the whole paradigm is based on the idea that subclinical AFib predicts clinical AFib, that subclinical and clinical AFib increase your risk of developing thrombus in the left atrial appendage, and that thrombus then goes on to cause an ischemic stroke, and that if you can intervene upstream with an anticoagulant, you prevent the stroke. The problem is that if you look at large studies of patients who have continuous remote rhythm monitoring at the time that they present with a stroke, a significant percentage of them don't have any subclinical AFib detected. That's the royal blue pieces of the pie here. So you could assume perhaps that their strokes were due to some mechanism other than AFib. The problem is that if you look at the gray and the yellow here, these small slivers, those are the percentage of people who had subclinical AFib detected either at the time they presented with their stroke or within the preceding 30 days prior to the stroke. And those are very small percentages here. At least that temporal relationship doesn't really seem to hold in the way that you would expect it to. And the light blue here, these are individuals who only had AFib detected after they had the stroke. All of the time that they were monitored prior to the stroke, there was no AFib detected. And so that really begs the question, is subclinical AFib just a marker of underlying cardiovascular risk factors, of a prothrombotic state, of some other mechanism that doesn't necessarily hold with this temporal relationship between subclinical AFib and stroke that the screening paradigm is based on? The reason for this discrepancy, people don't really understand, but I think we're going to have to understand this relationship much better in order to make rational decisions about when and who to anticoagulate. The false positive question, I think we've already alluded to, is a big issue, but I do want to go through a couple of sample calculations that have been published in the last couple of years or so that just highlight the challenges of screening enough people in order to have a material and clinically relevant impact on stroke. If you screen a large population of individuals who are relatively young and healthy, where the background incidence of subclinical AFib is about 0.5%. So this would be average sort of 40, 50, 60-year-olds, a little bit like the Apple Heart study where the incidence of irregular pulse notifications was 0.5%. That would mean you'd have to screen 200 people in order to identify one case of subclinical atrial fibrillation. Now, if you take individuals with a CHADS-2 VAS score of 2 or 3 or something like that, the absolute risk reduction in stroke risk from anticoagulation, absolute risk reduction is about 2%. Obviously, that varies a little bit based on your background risk, but on average, it's about 2%. which would mean a number needed to treat with anticoagulation to prevent one stroke of 50. But if you need to treat 50 people to prevent one stroke, and you have to screen 200 people in order to find one case of atrial fibrillation, that then means you've got to screen 10,000 individuals to then treat 50 of them with anticoagulation to prevent one stroke. So just the math in terms of screening starts to break down a lot if you look at a background population where the prevalence of atrial fibrillation is going to be relatively low. And these are the kinds of numbers that probably apply directly to the Apple study and even the HUAWEI study. The other problem is this issue with specificity. A lot of these devices claim specificity in the 90, 95, 98% range. But if the screening modality, whatever it is, watch, AliveCor, band, whatever, is 95%, and you screen 1 million people, and there's well over 1 million Apple Watches floating around out there, and assume that the background prevalence of AFib is about 2%, that means there's going to be 20,000 people out of 1 million who actually have AFib with a prevalence of 2%, and 980,000 who don't have AFib. Using a specificity of 95% with a false positive rate of, a specificity of 95% puts your false positive rate at 5%. If you screen 1 million people with a false positive rate of 5%, you end up with 49,000 people who are going to be falsely diagnosed with atrial fibrillation who don't actually have AFib. Even if you take that specificity to 99%, you still end up with about 10,000 people out of 1 million who are falsely diagnosed with AFib who don't actually have the disease just because the background prevalence is so low. And not surprisingly, this is a study from Henry Ford a few years ago where they looked at false positive diagnoses of atrial fibrillation from ECG screening. But about 10% of individuals ended up being inappropriately treated with medications based on the inaccurate ECG interpretation. And there was about a 25% rate of unnecessary diagnostic testing, echocardiograms, cardiology referrals, and things like that. So I think the false positives and the subsequent over-testing and unnecessary treatment is a real problem. And the false negatives we've already alluded to. We don't really know what the false negative rate is for a lot of these devices because those people who are wearing watches or walking around with their wearable devices don't have some other form of continuous rhythm monitoring to detect the background incidence of AFib that's not being detected. The one other thing is that we've already alluded to this, but the stroke risk from subclinical AFib is likely lower than the risk of clinical AFib. Now, it may be that when your subclinical episodes get to be more than 24 hours or so, the risks are about the same, but on balance, the risk seems to be lower with subclinical AFib. Now, how much lower, we don't really know. But whether the net clinical benefit still favors anticoagulation or not, I think is very unclear. This is a sort of a thought experiment that I think highlights the issue, but if you look from the RELY data with dabigatran, not surprisingly, the incidence of stroke increases relatively linearly as your CHADS-2 score goes up. Interestingly, the risk of bleeding also goes up as your CHADS-2 goes up, and a lot of studies have shown this. As you get older and you have more comorbidities and CHADS-2 score goes up, the bleeding risk goes up. The problem is that we know that there's a net clinical benefit to anticoagulation for clinical atrial fibrillation. But if your risk of stroke is lower with subclinical atrial fibrillation, whether the net clinical benefit still favors anticoagulation or not is very unclear because there's not a reason that I can think of where people with subclinical AFib would have a lower risk of bleeding from anticoagulation than those who have clinical AFib. So I think the bleeding margin is probably going to be about the same. And if the overall risk of stroke goes down, whether it still favors anticoagulation or not, I think is very unclear. So last slide, I think one more slide after this, but there are a lot of challenges to this data, right? The issue of confirmatory testing when somebody comes in and says that their device has detected AFib is, I don't know. I struggle with this in clinic all the time. Do you have everybody wear event monitors? What intensity of confirmatory testing do you do? When patients email us PDFs from their devices or send it through the clinical portal, how do we store that data? Is there reimbursement for the time and energy spent reviewing that data? And then there are medical legal questions, right? If somebody's device detects an irregular pulse that may be AFib, you have them wear a 30-day monitor, you don't detect anything, and then 6 months later they go on to have a stroke and you decided not to anticoagulate them. Is there any medical legal liability there? As far as I know, there haven't been any lawsuits based strictly on subclinical AFib detected by devices, but I suspect we'll start to see that. The companies are very aware of this. This is taken from the AliveCor website, but they've actually developed an interface that will interface with your electronic health record and send data directly from the AliveCor device into Cerner or Epic or whatever you happen to use. And they have CPT codes that they've generated in order to review the data and bill. So I think we're going to have to figure out as systems how to deal with this data moving forward. So to summarize, I mean, there's a lot of enthusiasm right now. Every week there's a paper published on AI or machine learning, looking at all these wearable devices and trying to improve the sensitivity and specificity for detection of atrial fibrillation. But I think at the end of the day, screening people where the low background prevalence of atrial fibrillation is going to continue to be a major problem because the false positives are overwhelmingly likely to frustrate any kind of benefit to screening. I do think that big data will, over time, as you link clinical electronic medical records with remote monitoring, will hopefully help clarify some of the relationship between burden of atrial fibrillation and subsequent stroke risk. And there are 2 clinical trials going on right now, Artesia and NOAA AFNet6, both looking at subclinical AFib using the 6-minute ASSERT threshold and randomizing to anticoagulation or no anticoagulation. Hopefully they'll help guide anticoagulation decisions. We'll have data over the next few years or so. I think that's it. Thank you. Yeah.
In your nature table that you use, do you know, there's a cutoff, the only people that it was really relevant for were high risk.
Yeah.
Cutoff of CHADS VAS greater than 2 in a man or 3 in a woman. I find myself taking it further, and in the difference between a CHADS VASC of 2 and a CHADS VASC of 4 is significant.
Yeah.
Do you draw that line after 2 and treat everybody the same, or do you?
Yeah, on balance, I think 2 at least prompts me to have a discussion. And if they're at inordinately high bleeding risk or there's some other compelling reason, but on balance for episodes lasting more than 12, 24 hours for people in their 60s, 70s, if the CHADS-2 VASC is above 2, I tend to anticoagulate.
Because, I mean, these tools, the negative and positive predictive values, like anything,
Yeah.
is prevalence dependent.
Yep.
So I feel that a 2 is very different than a 6.
Yeah, absolutely. Yeah, I mean, I tend to tilt toward anticoagulation in that regard. Age, I think, is a big consideration in my mind. I'm more likely to anticoagulate people as they get in their 60s and 70s, but I don't know the.
I've had the experience where patients have had a stroke and they have a high CHADS VASC score. And I've dealt with neurology, and my sort of thought was, let's try to catch the AFib, but in the meantime, anticoagulate.
Right.
They've been very reluctant to take that step. And what are your thoughts in that patient where we haven't caught it? And based on some of your data where the temporal relationship burden obviously plays a role, but what are your thoughts about that high CHADS VASC patient who's had an event that you think?
I've tended to be much more aggressive about implanting them with implantable loop monitors, but looking to document something before committing them to anticoagulation. Again, those same really high CHADS-2 VASC people also tend to be the people who have complications from anticoagulation. So I feel incumbent to try to document something. Whether that's the right answer or not, I don't know. Like I said, those 2 randomized studies, RESPECT and NAVIGATE, didn't suggest that empiric anticoagulation was beneficial, but so I've tried to look more intensively. And again, whether that's the right answer or not, I don't know.
Thank you.
Another way to detect atrial fib is to ask them to buy one of these.
Is that?
That's a pulse oximeter.
Oh, yeah, okay.
And you can get that on the internet for less than $20. You have to be careful about interpreting it. But I tell a lot of folks to do that. I don't think anybody else does it, though. You tell them to get one of those? You tell them to get that? It's the same. Yeah. Well, that right there is less than $20. So when you see a pacemaker report that has 2 seconds of atrial fib or 3 seconds of atrial fib, how about telling us about the mechanism by which that pacemaker algorithm, tell us whether or not it's atrial fib, and does all of that stuff get added into the AF burden?
So strictly speaking, a device doesn't really look for AF per se. The burden that's reported is something called a mode switch burden, which is a programmable parameter. Anybody's got an atrial lead, pacemaker, defibrillator. If the atrial rate goes above X, and by default on most devices that's set above 180 beats per minute or so, regardless of what the ventricular rate is, but if the atrial rate goes above the mode switch cutoff for a particular number of beats, the device records that as a mode switch event, and it actually prompts the device to switch the pacing algorithm to something that won't track the atrial rate, because you don't want to pace the ventricle at 180 beats a minute if you've got an AFib. So strictly speaking, what these devices are detecting are mode switch burden. There are a lot of mode switch causes that are not AFib, and so when we get these reports, we actually try to adjudicate the electrograms. Is this sinus tach? Is it SVT? Is it something else? Is it noise on the device? And so we have to be careful. Not everything that is a mode switch event or reported as mode switch burden is actually atrial arrhythmia. And in the device trials that you look at this, they actually report atrial high rate events, which are adjudicated as being AFib. But whether it's AFib, a flutter, and whether the stroke risk is different is unclear.
So that when that comes up on the pacemaker report, you guys have looked at the atrial electrogram.
Usually, if they're stored. Now,
We as you.
What's that?
We as you.
No, I know that. But so what I'm saying is a couple caveats. One, they don't always store the devices, so it depends. It's device specific in terms of what gets stored and how long it gets stored. Sometimes there'll be mode switches, but the events won't be stored. If we can look at them, then usually the device, our arrhythmia clinic folks who are excellent at doing this, will have looked at them. If it's pretty clearly AFib or pretty clearly noise, they won't report it. If there's a question about it, they'll usually send it to us. But it's been adjudicated at some point.
The preceding program is copyrighted by Emory University.